Hey guys, welcome back to our YouTube channel. Thanks for staying tuned. Thanks for joining me today. For those of you who are following along, Mo and I have just celebrated our 5-year wedding anniversary. So we're just coming off of that wedding weekend celebration. We spent the weekend at the Renaissance Hotel, which is actually the hotel we did our wedding reception at 5 years ago here in Columbus. It was a nice time to kind of relive some of those fond memories. In addition, Mo, for our 5-year anniversary, got me this, which is a Nerd Bugs model of a vertebrae. Basically, because she knows that I love spine surgery and I love spine health and taking care of patients with any sort of spinal disorders, spinal pathologies. And so this is a very cute sort of stuffed animal version of a spine. And so this is going to be in my office that I'm going to be having soon. But the purpose of this video today is actually I've spent the last 2 months as the chief resident on the neurosurgery spine service at Ohio State. So I'm going to talk to you a little bit about my time and tell you a little bit about what that day-to-day is like, as well as some of the case variety, some of the daily tasks, and kind of my overall perception, and share with you how much I've enjoyed it. So first and foremost, our spine service tends to be our biggest service of neurosurgery at Ohio State. On that service, we have a total of 4 residents, and I was the chief resident, so there are 3 other residents who are on service under my guidance. And so we had 1 senior resident, PGY 6, as well as a junior resident, either PGY 2 or 3, and an intern who helps cover the service as well. So every day, part of my role as the chief resident on the service is to determine the case assignments, determine who's going to be holding the consult pager, and determine which patients who we're following that need to be rounded on, and which patients we're waiting for imaging on, as well as looking through all of the patient's imaging, determining the patient plans for the day, and then calling the attendings, talking to the attendings, presenting our patient plans. Once those are finalized with each of the different attendings, then I will give those final plans back to the intern, and then the intern's job for the day is to complete those plans, and then I usually will touch base with the intern in the afternoon or again in the evening to kind of follow up on some of those plans, again follow up on the imaging, those sort of things. After I make all the phone calls in the morning, this is around like 7 in the morning, after I make all those phone calls, after the plans are all set up, then I would usually head to the OR. This ORs usually start around 7:30, as well as I would have given the other residents their OR assignments the night before, so they have time to prepare for their cases as well. But usually our rounding is done by around 6:30. We start to make the plans, and then everyone disperses to the OR around 7:30, with the exception of the intern who's on the floor, making sure all the plans are getting done, coordinating those plans with the social workers, with the other teams, talking to the primary teams, as well as talking to consultants for patients who are on our team, who are on our service, who need additional expertise by other services. Part of these 2 months, I have been exposed and really sort of perfected a variety of different spinal pathologies or subsets of surgery within spine. These include spinal oncology, so patients who have various types of cancer that have metastasized or have that spread from, for example, the colon, from the breast, and many other organs in the body to the spine. So those patients oftentimes have multiple medical comorbidities. We have to really kind of talk to the teams. So that's an interesting subset of spinal neurosurgery that I've been fortunate enough to have a good chance to really hone my skills and really perfect the management of those patients. In addition to spinal oncology, sort of the biggest subset of spine surgery is probably degenerative spine. Basically, as we all age, we have arthritic type changes, degenerative type changes. Basically, many patients with age-related wear and tear on the joints, on the bones, on the ligaments of the spine, on the discs of the spine, and so these can present in various ways, and so that tends to be the bulk of spine surgery. I've done a number of cases with patients with degenerative pathologies. So here's an example of a patient with degenerative pathology. They've had a previous lumbar decompression and fusion surgery. They developed stenosis at the adjacent segment, and they ended up having to undergo a surgery to decompress that level and fuse that level of the spine. These are our post-op x-rays. As you can see, we instrumented and decompressed that level. Another subset of spine surgery is trauma. Many people who have car accidents, who are pedestrians, who are hit by motor vehicles, or who have falls, especially around this time of year. It tends to be summertime where people are playing sports. There are a lot of ATV accidents, bicycle accidents, those sort of things. In addition to elderly patients who fall, who have compression fractures, those sort of things. So here's an example of a patient who underwent a motor vehicle collision and had a burst fracture. We ended up taking this patient for a spinal surgery, basically to fuse those elements of the spine. We fused 2 levels above and below that fractured segment so that the fracture can heal and the spine will be stabilized. For those of you not from the Midwest, we in the Midwest have a big issue with IV drug abuse, and so these patients often present with various abscesses, and a lot of times these can affect the spine. The problem with abscesses in the spine is that oftentimes they are compressive. They are between sort of the bone and the discs, and also then they can spread and become larger and form phlegmon, which then compress the spinal cord or the spinal nerve roots, then causing very severe back pain, weakness, loss of bowel or bladder function. And so those patients sometimes can need urgent intervention for decompression of the spinal elements as well as fusion, because their spine is oftentimes unstable because so much of their bone has been eaten away by bacteria. This is a patient with a spinal osteomyelitis and discitis. As you can see, the infection is lighting up white. This patient was neurologically intact, and so we elected to do a percutaneous fusion of the thoracolumbar junction in order to stabilize that spine, because that bone was being very eaten away by bacteria. I want to talk to you a little bit about techniques for spine surgery, and specifically for putting in pedicle screws. A lot of times for spine surgery we do rods and screws to hold the spinal elements stable. And so there are a variety of ways in which we're able to insert those screws. Some of those are freehand technique. Basically, we open the spine and just using anatomical landmarks, we're able to determine the entry point and the trajectory for each screw. Sometimes we use X-ray guided screw placement, and sometimes we use navigation guided screws, which basically is like a GPS system that we hook onto the spine, and we're able to see the anatomy on a screen, which is projected there, and then we're able to insert the screws according to that projection on the screen. So I'm feeling very well versed in all those aspects of spine surgery. That's actually going to wrap up my time as a chief resident on spine surgery service at Ohio State. And for the next 2 months, I'll be the chief resident of the tumor service. So basically, patients with any sort of brain tumors or spine tumors, whether that be tumors that start in the brain or the spine, or have patients with other types of cancer that have then spread to the brain and spine. So now I'll be involved with caring for those patients. So overall, it's been a very terrific 2 months, and I'm very much looking forward to my time as the oncology chief resident of that service and caring for those patients as well. So with that, we have some grocery shopping to do. It's about 5 o'clock now. Gonna go to the grocery store, start to get things ready for the week. It's actually a short week for us this week, only 4 days, because today, Monday, is a holiday, which is very nice. So gonna go to the grocery store, pick up some things that we're gonna need for the week, and then start unwinding and getting ready for bed. All right, see you guys.
Every time you feel the walls are closing in, and it seems like nothing makes it better, you should try to remember that's just how it is when it comes to love, comes to love.